Bartosz Wysoczański, and with my colleague, we want to present you some findings, some ideas, how to treat, how to manage the problem, which is shoulder pain accompanied with the subject of our presentation. And I will just trying to show you that presentation and why I am not able to.
Agnieszka, try to stop your presentation.
She already did.
No, she didn't. That's why.
She did. All right. Okay, maybe that's why I pressed that button and this button. Okay, it is loading. I think you should be able to see it just now.
Yes, we see it.
Great. All right. Okay. So, physical therapy of patients who underwent arthroscopic intervention on the shoulder joint for adhesive capsulitis, or capsulitis, if you rather like to use Latin words. The problem is, well, we have a problem. I mean, we as a population, because it is estimated that from 2 even to 5% of the general population have this disease, this syndrome, we could sometimes say. But we all already know how the arm, how the upper extremity works. We know how the capsule is built. We know that the capsule ball or the joint ball is bigger than the part on the scapula, and it leaves us to the great range of motion. In the same time, we are able to stabilize it. We are able to stand on our hands. Well, some of us, we can lift heavy objects and so on. So this group of joints, which will be connected to each other, acromion, scapula, and arm, have to work together. If there is some kind of a problem in any of those of those bones and joints between them, or with any of the muscles of the shoulder girdle, we will have a lack of motion, problems with the strength of that complex, and active movement. So we know that the range of motion should be great. We know that the range of motion should be great enough to give us a possibility to scratch every part of our body, to wash every part of our body, to touch every part of our body. If not with one hand, then with the other. If we are not able to do it, there is a clinical problem. Most possible that there is a clinical problem that we, medicine doctors, physiotherapists, have to struggle with. How it is built, I think we already know, at least we think we know, because the last findings about soft tissues, about fascias, about the connection between the muscles and the joints, by the tendons, by the ligaments, we already know, but we are still examining it. How does the contraction of one muscle will make the other muscles to contract with them, to help them to make a movement? How it is possible that the that the capsule will also be stretched or relaxed after the muscle work, or the problems or the problems with the bones, if there are some marrow problems, for example. We are still trying to do some research in that area, and we are trying to examine how we can prevent the loss of movements or the loss of lacks of mobility. If there's normal injury, we more or less know what to do, right? We can do some rehabilitation exercises, physical therapy. On the first few days, we can use a sling or a plaster or some kind of orthosis or other orthopedic devices that will help to heal that arm, that joint, or the injuries in that region. After that, after rehabilitation, our patients are usually healthy enough to again start to do some sports, some activities, their usual hobbies, or just go to work without any bigger problems. But if there is sometimes there is a problem with so-called frozen shoulder. Frozen shoulder is, well, I think it's a really great name for that kind of lack of motion, of this disease, we can say, because adhesive capsulitis, it tends to be sometimes, well, maybe not now. Maybe I will tell it more afterward. Adhesive capsulitis. Adhesive capsulitis is, well, adhesive. So we have adhesion of the capsule. Capsule will be more stiff. It will contract. Their tubes, which is made of their collagenic tubes, will contract and become inflamed, as you I think already know. Clinically, our patient will feel pain. Pain is not always very big, very great. Sometimes it's about 1 or 3 on the VAS scale, but the lack of motion will be in those persons predominant. Clinically, the pain will occur on the deltoid region, so not in the joint itself, more on the upper region of the deltoid, maybe even a little bit further down, proximally. And here on the forward section of the complex, near coracoid processes. There are two main areas where the pain will occur. Decreased range of motion is a chief characteristic of adhesive capsulitis, but pain is described as because pain is described as purely localized, dull. It may radiate down to the biceps, even reaching overhead or behind the back. It may stimulate the sensation of the pain and stiffness. There could be some other symptoms like fever or night sweats, malaise, or even unexplained weight loss. But if there are any, they of course should be properly examined by the physicians, by the medical doctors, to consider an alternative diagnosis, such as neoplasm or some autoimmunological diseases. Also, the presence of neuropathic symptoms could suggest cervical problems. So sometimes when you are almost sure that your patient could have frozen shoulder, please check if they have any other symptoms, neurological, other pathological, that could raise yellow flags or even red flags before the other examination or the physiotherapy treatment. Stiffness. Stiffness, most patients feel it, but I think that the term stiffness should be used more for a patient that feel their own body, that they are sportsmen, for example, the people who like to move, who know how to move, who know how is or what was their natural muscle tense before this illness. And dysfunction, as I said before, the dysfunction and lack of the full range of motion. As you can see on those pictures, most of our patients will be like this guy. They will not be able to raise their hand, their extremity, to put it on their back, to scratch their head. So the two main questions I am giving to our patients, to my patient, is: can you comb the hair if you have any? If you don't, like me, can you fasten your bra? If not, like me, I have to try another things, another test, another clinical or another functional tests for those patients. But most likely the patient will tell you, I am not able to raise my hand. I don't know why, I just can't. Or I can't because I feel pain. Yeah. Impaired range of motion is mostly in forward flexion, abduction, and internal rotation. Those are the three main areas of the three main motions that are problematic. However, at the very beginning of the freezing process, there is also there could be also some restrictions in or of external rotation. So when you examine your patient, just check the range of motion and ask what happened, how does it feel, maybe touch with your hands and try to feel and to push those magical buttons. This one of the magical buttons to examine your patient is on a coracoid process, because when you put your finger here and press it, your patient will feel the pain. It will be much bigger pain than in the acromion, in the acromion region, and much more. It will be much more pain than on the deltoid near the bursa. So you have to push here, push here, push here. If the third one here on the coracoid process is the most painful, you have 70% chances that there is a real frozen shoulder, because sometimes we call the frozen shoulder any kind of problem with the mobility of those joints, and we shouldn't do it because the treatment is not the same. Another thing that is good to see, but good to examine, to check on our patient, is how they walk. With the gait analysis, we can see how those upper arms will move. If they're moving correctly, if the swing is the same on one side and on the other. If not, there could be a problem with the stiffness of the capsule. Further examination of the affected shoulder may reveal muscle atrophy. So another thought we could have is, okay, if there is a muscle problem, maybe there is. Maybe we should check the muscle work. Maybe we could use some EMG if we are able to do it. So, based on those assumptions, we should stretch and mobilize the tissue. We could stretch it. Well, we have a lot of not ideas, a lot of. Oh, sorry, I forgot the Polish word. We have a lot of stretching exercises. We have a lot of clinical mobilizations, sometimes very aggressive, that we can use. But if we could we really use it? We'll go back to that slide for a few minutes, all right? What will help us? What will help us to treat our patients? Adhesive capsulitis is often self-limited. That is a good thing. It will end. It will stop the freezing of the shoulder. After a few weeks, more maybe rather a few months, it will be defreezing with the time. However, it can persist for years, with some patients never regaining full function on their shoulder. Some papers show that this frozen shoulder should be defrosting for 1 or 2 years, but the documents from 2017 and from the last year, if I remember correctly, tell us that some patients have this problem with the adhesive capsulitis even for 12 years. So for some more active persons, 12 years without a full range of motion is just a tragedy. So maybe we should try to take care of. Why I'm talking about this? Because some physiotherapists and some medical doctors, some physicians say that we don't have to treat it. We don't have to treat it. We need to just wait, and our body, our organism will heal itself. Sometimes yes, sometimes it's true. Sometimes after a year or two, the joint will heal. This capsule, the inflammation in that capsule will get back, and everything will be all right. But not all of them. On which I think we should try to at least relieve the pain for our patient. The history of creation. You can find this diagram or similar to that all over the internet, all over the researches about frozen shoulder, about adhesive capsulitis. On the first days, first months, there is not a big pain, quite good range of motion, but it starts to decrease. The pain grows bigger. It's called freezing. Then after a few months, the pain gets worse. It is even 7 or 8 in a VAS scale. The range of motion could be this disability which will conquer will be so big that the patient will not be able to do any kind of motion of his upper extremity. After that, the next phase, called thawing, lasts about 2 years sometimes. The pain is decreasing, the range of motion is increasing. But as I said before, we shouldn't look at those numbers because each patient is different. We are not able to predict how it will be after a month or two or a year or two. Even if the patient is a sportsman, it doesn't mean that it will heal properly. So why should use that? Why I sometimes use that diagram to show my patient that there will be, if he's in this first phase, freezing phase, that it will be worse. I'm sorry, but it will be. We could try to relieve the pain. We could try to get this range of motion as big as possible, but it will be worse. But after that, it will be better. How much better? I'm not able to tell about it to my patient. I will not try to tell about it to my patient. There are two types of adhesive capsulitis. Primary, idiopathic, when we are not able to tell how it occurs. Mostly it appears in a group of the females from 40 to 65 years old. Some of them have previously the same problem on the other limb. So if there is a woman with after the frozen shoulder, it is possible that the other shoulder will have the same problem for a few years from that point. And of course, secondary. Secondary could be systemic. Example of the systemic are people with diabetes or thyroid problems, so some kind of autoimmunological diseases, and extrinsic like stroke or other trauma, not near the frozen shoulder region, and intrinsic fracture, dislocation, tendinopathy on the region we are talking about. So when there is a struck, there is some kind of injury, we could think that okay, there was a hit, there was some problems with the soft tissue, there is some scarring, maybe that could cause a frozen shoulder, and it could, not always, but there is a possibility. But a few years ago, I have a patient. She was with her young boy, with her child on. I don't remember now if it was skiing. I think she was teaching him how to ski. No, skating, ice skating. She was teaching him how to perform on the ice skating, and she was so afraid that he will fall and do harm on himself. She was still grabbing holding his hands like this, and for the half of an hour she was skiing. She was skating with him like this. After that, everything was okay, but after a week, she felt a pain in the coracoid region. After 2 weeks, she came to us. She wasn't able to move her hand. She had some problems with external rotation, internal rotation, adduction, and so on and so on and so on. After examining her, after ultrasounds, well, it appears that it was a frozen shoulder. So this stiffness and stress caused by this thing that should be fun caused so a big and inappropriate response on her organism that frozen shoulder occurs. Axillary fold and contracted axillary fold are almost always appeared in this adhesive capsulitis illness. It could be shown on an MRI. Yes, here it is. It could be shown on an MRI. You can see now on the A photo, there is a normal image. Look at this yellow dot or yellow star. You see there is a capsule, there is a normal thickness of the capsule and the axillary pouch. On the B, the capsule thickened and the axillary pouch contract a bit. Great. Okay. As I said before, it is good to see, it is good to touch the coracoid process and the region where the, and the region where the ligament, coracohumeral ligament is, because this ligament is one of the ligaments that will thicken the most. It appears that the inflammation could begin in that region. So that's why when you push it, the patient will feel pain. And of course, always check the others. Check if there is no dislocation, if there are avascular necrosis or maybe fracture, maybe rotator cuff tear or tendinopathy, maybe glenohumeral arthritis. Always we can use RTG to examine the bone structure, the arthritis, and so on. But MRI will be much more helpful in that. Diagnostic testing. Diagnostic testing. MRI findings that this ligament is thickening, rotator rotator internal inflammation of the subcoracoid fat could occur, and this recess yield high specified for adhesive capsulitis. So MRI could help you, but I think that touching that region, palpating it, and using ultrasounds will be a bit better, or could be or should be used also to evaluate, to be sure that we have a patient with a frozen shoulder. Because all of those kind of examinations, of those diagnoses, MRI, RTG, ultrasounds, should be reserved mostly for finding if there are other sources of the problem with this pathology, of this shoulder pathology. Not just to confirm the diagnosis you can give. Restrictions of movement. I think we all know that kind of patients that are unable to do external rotation. The same with adduction. As you can see, this no, maybe not here. This lady, when she's trying to adduct a little bit more, she's tilting her body, which is a normal thing. This occurring very, very often in our patient. Click. Some tests. Testing. I'm sorry. Normal physical therapy. Physical therapies have a big range of tests. We have whole books of clinical tests. A few of them are better, few of them are not so good. Job test is one of the better, I think, for checking if there is a problem with supraspinatus. Job test, also named empty can and full can. When you ask your patient to raise his or her arm, and she will feel a pain in the region near the coracoid process or upper shoulder, we could say, in the region of the upper shoulder, and she's not able to hold it. We can do the passive movement, release the arm. If it will drop, it's called the drop arm test, and it says us that there is a problem not in the joint, but most probable that there is a problem with the deltoid muscle. But if you rotate the whole limb in external rotation, if you rotate your limb in external rotation, there should be an acromion. The area under the acromion, under the how is it called? Not acromion, but this processus. I lost it. Okay, but it's maybe here. It's closing. On the external rotation, it's starting to get more closed than before. And supraspinatus, which is going just here, it could be squished between two bones. And when it is, our patient will feel pain. If the test is positive, it is most probable problem with the muscles, but not with the capsule itself. The same we could say with O'Brien test, when our patient will have problem with the biceps tendon or SLAP, so superior labrum, anterior posterior. When our patient do that movement and rotate inward, external rotation, the capsule will be, if the capsule will be stiff, she will not be able to raise her hand, but when she will do external rotation and feel pain, there is a problem with the biceps more than the capsule itself. Sulcus test. Sulcus test is made for imbalance of the muscles or a problem with the sometimes natural, sometimes neurological, too big range of motion. This is a normal joint, and when I grab the arm and pull it down here, just on the upper side of the humerus, it will appear the sulcus, the hole in the skin, which will be quite visible. Sometimes it occurs in gymnastics or swimmers. Relocation test. I think you already know it. There are two types of those tests. One, when you push the head of the humerus downward, and after gentle push, you release your hand, and the humerus will go back, sometimes with a click, sometimes with the pain. If it is doing like this, we can call it unstable shoulder. Or in that position, you can do even more external rotation of the arm, and the whole head of the humerus can go forward and relocate, so not relocate, dislocate on the forward section. If you are able to do that test, the problem is not in the adhesive capsulitis, but there is a problem with the capsule. Yeah? It is not stiff enough. Near test, it's an easy one. You can just ask your patient to raise his arm. If he's able to do it without pain, everything is all right. If not, there's a problem with impingement syndrome. Another one, bed cop test, very great name, compression and distraction on the AC joint. You can push by the elbow or the whole arm upward, and then grab it and pull it downward. The pain, I'm sorry, the pain will be localized in the AC joint. If it will, it is not a frozen shoulder. As you can see, most of the tests on the muscles, on the joint, or on the joints are not to examine if there is a frozen shoulder, but if there is something else happening there. The same with MRI, RTG, and so on. Okay, so what to do if we already examined our patient? We know that there is adhesive capsulitis. We already know that. We try to do some work with him, to do some physiotherapy. Researchers said that there is no good way, there is no proper way to make a physiotherapy, to rehabilitate this problem, sadly. We are trying to connect our work with the work of other physicians. Sorry for a moment. So exercise by itself or stretching is not enough for adhesive capsulitis. We can do injections. We can do injections on the joint or just on the capsule, and it should help our patient relieve the pain. Do this thing increase range of motion? Well, no, not really, because the stiffness is still there. This adhesion is still there, but you relieve the pain, so the patient will be much more joyful, we can say. And after that, we can try to do some exercise. So basic on those assumptions, we should stretch. No, not really. At least not aggressively, because when you stretch aggressively, this kind of tissue, this inflammation will be much bigger, much worse. So try to understand that mechanism, this defense mechanism of our body, and do not stretch and do not mobilize the tissue, at least not aggressively, even if you do some injections to the joint. What can we do? Well, we can wait for operation. We can do manipulation in anesthesia. When the patient is sleeping, this procedure shown here on those pictures is not very common, because the practitioners, the physicians, afraid of fractures, afraid that they will destroy the other fragments of the body. Because when the patient is sleeping, the doctor will hold his arm and mobilize it, manipulate it so extensively that this capsule will tear down. If it will be teared after a few weeks, it will heal, most probably without inflammation, and the range of motion will be bigger. Yeah, it is proven. It is proven. It's not just their idea to, hurt the patient or do this aggressive mobilization about which I was talking just a minute ago. After the anesthesia, we don't know exactly why, but the body will not we will not make this joint in a more stiffness position or in the more inflammatory on more bigger inflammation. What other thing doctors could do? They can do an operation. They can do an operation, arthroscopic intervention, which is subject of today's lecture. But arthroscopic intervention is curious because they go inside the capsule and just cut it all the way around. So it's almost loose. The arm is almost loose. It's mostly on a few ligaments and the muscles. After that, the capsule will heal, and it will heal quite good without the symptoms of the frozen shoulder. But the thing to remember is that just after the operation, the patient should be in the right position, like this on the photograph. At least at the first night following management of adhesive capsulitis. And a few days, sometimes a week after the operation, during the sleeping, the patient should be aware that he is not able to lay down on that arm, and it should be raised and elevated like here. So, to the rehabilitation. On the first phase, up to 2 weeks, 2-week goal is to minimize the pain of our patient, to ensure him to ensure his mobility will increase. Light tasks, functional tasks, just when the block wears off, we could try to do with our patients. We should taught them how to move their capsular stretching, how to do the capsular stretching exercises, how to move their capsule. Again, lack of the word. Shoulder blade, their shoulder blade. We have to tell them that they should avoid stretch during the sleep. So it will be a good idea to tighten the upper arm to the upper extremity to some kind of orthosis, maybe. And for the physiotherapists, we should mobilize the capsule. We should do some passive movement, mostly from the psychological view of the patient, when he will see that, okay, he will not able to move the arm because of the pain, because of the swollen arm, but we are able to do it passively. He'll think, okay, if you can do it, I will be able to do it for a few days. And normalized movement patterns. Active movement, teaching of the active movement should be efficient enough to, from the first days, from the first weeks, teach the patient to use their limb properly. Because on the last period, when the shoulder was frozen, they were not able to move it, and they were compensating with the whole body.
Bartosz, are you here? Let me check what happened.
I call to Bartosz.
Okay, I'm back. Some connection problems from my side, I think.
Yes, that was something wrong.
Okay, but now I think it's right. I'll try to restart the presentation.
We'll see the presentation.
You do? Oh, because
Yes.
I don't. I don't, so I'm not able to change the page.
Okay, now we see your PowerPoint, and now presentation again.
I think I have to log off and log on again because I'm not able to change the pages of the presentation.
Okay, please try.
Okay. I see it now. Do you hear me?
Yes, we hear
Great.
you. And now we see the presentation. 2 weeks ago.
Yes, 2 weeks ago, 2 to 6 weeks. Another increase the range of motion, enhanced proprioception, and that that point is very important, and optimizing kinetic chain. Again, physiotherapist should perform joint mobilization. We should perform passive physiological movements as before, with the assist of the patient if possible. We should add active range of motion up to the feeling of the pain of the patient. So we are not trying to work in the pain with our patient. We should try to ensure continuation of home exercise also. So give your patients some ideas, some program to work with at their homes. From 2 to 6 weeks, we could add strengthening exercises, even with some quite heavy weights, for example, 2 kilos, but they should not feel any pain doing those exercises. And remember that the more important is the range of motion than the strength of the arm itself. So when your patient is not able to do the correct movement, the physiological movement of the extremity, when he has some dumbbells, some weight on his hand, don't do it. Go back, make a few steps back, teach him the normal anatomical movement, and then add some strengthening exercises. Next phase, up to 12 weeks. Again, active range of motion, continuation of the mobility and stretching, continuation of rotator cuff activity. During elevation, we are trying to do some exercise, some activities on elevation, even quite high elevation, and progressive proprioceptive work in close kinetic chains. We could add dumbbells, we could add kettlebells, which will teach our patient how to use their limbs properly. So now in that phase, we are trying to stress a little bit our patients to give them more sport activities, maybe not exactly sport specific, but if we have a sportsman, he or she should do at least some normal activities for them. For javelin thrower, we could try to maybe not throw, but try to do the movement they will normally do on the field. And after that, more strengthening, more sport rehabilitation, more enhanced rotary cuff power through the range, plyometrics, force production, more strengthening, continue home exercises even for another year, because there is always a possibility that this frozen shoulder could come back after the operation, after the arthroscopic intervention. It's not so often, but as I said before, there's not a lot of that kind of interventions done in Poland, in the world, because we are trying to find another way. We are trying to use almost always only physiotherapy to help our patients. And arthroscopic interventions are used where there is no progress on the normal classical physiotherapy or normal classical physiotherapy with injections. So first of all, we will try to, because I'm not changing those. We are not trying to, we are trying to do some exercises. After that, we are do some gently stretching. If it will not help, we will try the injections. And after that, if the injections and physiotherapy doesn't work, we can do arthroscopic intervention.
Bartosz, we don't see changing the presentation. There is still 47 slides, so 0.
47. Okay. How's it now?
Now is the same, 47th in my screen, on my screen.
And now?
Now 49.
Okay, I will go
Which
back.
slide should be?
Now should be 48. 48.
Okay, I don't know why you are not able to change. Now I change slides, I can do it.
You can do it?
Yes.
Okay, so we can change to another one.
49.
49. Just to show that I have it. And the next one. This is the last step. When I was talking about another strengthening, another sport-specific rehabilitation, and continue even year after the healing process to continue the home program. And I will try change it. Did I? No?
No. No.
Okay. Yes, I think that you have to do it. So could you please?
51.
Okay. Yes, 51. Few ideas how to do the examination and traction. We can use the whole range of mobilization from Kaltenborn and Evian to mobilization from Brian Mulligan or any other concept, Syriacs. It's up to you. It's up to physiotherapists which one of those concepts they will use. All of them have their own meaning. On the beginning, I think that the Kaltenborn is better because it doesn't need to it doesn't need from the patient to do an active movement, because you do this mobilization, this traction passively. But after that, when you reach some kind of range of motion, you can add the Mulligan's mobilization to with movement, the mobilization with movement. Next slide, please.
I changed.
The shoulder joint. Okay. Traction mobilization. Again, when the patient is laying down, he's fastened with the belts to the table. And the next one, gliding, also really great for abduction of the arm. And about gliding, we should always remember that when those bones glide, they should be on the beginning. They should be going downward. But when the range of motion is quite great, and the patient is able to raise their hand just up on the air, the glide should be upward. The movement of the joint is not so easy. It's not going always downward, but it's like number 8. So you are going down a little bit back and then up a little bit forward during the mobilization. It all depends how high you want to raise your arm. Next one. Just another position for the glide. This glide for external rotation, and the glide itself is made downward, so forward of the patient. Okay, next. And next. And that is an exercise. Exercise in few on this first 2 weeks after the operation, when the patient is just bent down and trying by itself do some passive movements of the arm. The arm is just swinging here and there, up and down, up and down anatomically, but you can also do an abduction with that kind of movement without pain. Just use some gravity. And next. Oh, another view of that. And the next. To teach and how to do passive movements, abduction, adduction, or even extensions. You can put the arm on the ball, or maybe on some kind of a rag of tissue, and move the whole body. Move the whole body in that way. The arm will be moving passively. So you have to relax your muscles, put your hand, let it be laying down on the table or on the ball, and rotate your whole body one side to the other side. If you have a chair on the wheels, it will be great, because then you can go further away and go back to the table when your hand is lying down. And next. As I said before. And the next. Yeah, strengthening. Strengthening, kettlebell training, proprioceptive training. When you are able, when the patient, when our patient is strong enough, and you are able to teach them how to use the kettlebells, it will be great for them, for the whole core exercises, so for the muscles of the trunk, for the muscles of the shoulder girdle, and for the lower extremities. We were talking previously about that the compensations that occur in our patient could cause them some back problems, some scoliotic problems, even pain in the head, in the neck, stiffness of the neck. So when we are going back when we thinking about that, we want to get them back their whole range of motion of the whole body, and yeah, use the hand properly, maybe teach them how to rise, how to stand on their hands, because why not? Next one. And that's it from my side. Thank you very much. I hope you enjoyed the lecture. and everything was clear. I was trying to do it so.
Thank you very much, Bartosz, for your valuable lecture. It's time for some questions or opinions, so feel free to ask Bartosz.
I know it is a hard subject because very few physicians do that kind of operation of arthroscopic intervention during the adhesive capsulitis, because they are afraid to. Why is that? Because when you do something, when you do some kind of operation on the shoulder, it is possibility that something will go wrong. What does it mean? That our body will develop inflammation in the regions that they were not touched even by a chirurgeon. My friend who did a lot of operations and quite few interventions, these arthroscopic interventions, always said that when you just want to examine your patient and do so-called white arthroscopy. White arthroscopy is when you do an arthroscopy just to examine what is happening there in the shoulder region. It is a beginning of the white arthroscopy is a beginning of the black cycle of events. Because after that, the muscles will be going to turn down. We don't know why exactly. The bursa will go into inflammation state. So that's why I think a lot of medicine doctors will not want to do that kind of intervention. So just for you to know. That's why we are trying physiotherapy first, and some injections. The injections could be from corticosteroids or without steroids. As always, corticosteroids are the, we can say, last line of defense.
So I don't see questions on the chat and raised hands. We finished a little earlier, so thank you, Bartosz, again for your presentation. Thank you, Krzysztof,
Thank you very much. It was good to
preparing it.
be here.
I think, yes, please tell. I think that we can stay as organizations a few minutes. Maybe someone want to ask individually. So thank you very much, everybody.
Thank you very much. Oh, I just
in such a huge group.
I just remind myself about one thing. Because we have some time, so I will tell about it. That there is an idea. That there was an idea to make a range of motion bigger, better after when the adhesive capsulitis occur, or even after other kind of problems after surgery on the shoulder region, because sometimes we could inject a fluid into the joint just to make it a little bit wider, we can say, when you inject fluid, the bones will separate more, and that separation will stretch the capsule itself. I know that some physicians do it. For example, of our hospital, the hospital on I don't remember the exact name because it's quite long, but it's hospital for an army, and they use it. They use this injection as a separation to make the capsule a bit loose, a bit more stretched, and to give their patients after a week or two the bigger range of motion. So, well, it's not our job, not physiotherapists, because I'm the physiotherapist also. It's not our job, but it's good to know that there are some findings, some ideas how to help our patients other than arthroscopic intervention. Thank you.
Thank you, Bartosz. So I think that we can finish slowly. So thank you very much for your attention. As I said before at the beginning, me or your university will send you a certificate. So be patient and please wait a few days for it. I wish you a very nice afternoon and a nice evening, and stay good, take care, and stay healthy. Thank you.
Thank you very much. Have a nice day.
Thank you again. It was good to have you here. See ya.